here. This is Marcy Nielsen. I'm the CEO of the PCPCC, and I have lost my voice. So I wanted to thank our friend Jeff Coughlin from the Healthcare Information and Management Systems Societies, better well known as HIMSS, the Senior Director of Federal and State Affairs, for being here. And I'm going to turn it over to Caroline to give the introductions. Thanks, Jeff.
Thanks, Marcy. So yes, as Marcy just mentioned, we have Jeff Coughlin here today from HIMSS. Today he'll discuss some of the major health IT public policy issues facing the community in 2015, specifically focusing on enabling interoperability and health information exchange from a regulatory as well as a legislative perspective. In addition, he will talk about the Meaningful Use program, some recent electronic health record adoption numbers, and where the program is headed with the recently released Stage 3. So before I formally introduce Jeff, I'd like to quickly go over some housekeeping announcements. From PCPCC, I just wanted to let all of you know that the CAPG Annual Health Conference is taking place June 11th through 14th in San Diego, California this year. And we are actually co-hosting the conference and having a pre-conference there. The session is called Primary Care Innovation in the Patient-Centered Medical Home. And at that conference, we'll present innovative primary care strategies organizations are using to improve population health and strengthen patient and community partnerships. So again, that'll take place on June 11th from 1 to 4:30 p.m. PT. So you can register at that at capg.com. So going on to housekeeping items, please use the webinar software to ask questions or provide comments. So to do this, you can submit your questions in writing using the drop-down question box on your screen. And after Jeff goes through his presentation, during the last 15 minutes or so, we'll go ahead and ask those questions to Jeff, and so he can provide you guys answers. Also, just note all of the slides and the recorded presentation from today will be available on our website within 24 hours, and so you can go to pcpcc.org to find those. So now it is with great pleasure that I introduce today's speaker. As mentioned, Jeff Coughlin, the Senior Director of Federal and State Affairs of HIMSS, is joining us today. In this position, he's led HIMSS's efforts to build stronger relationships with federal agencies and facilities, and facilitates the building of a nationwide network of advocates for state-based initiatives that impact all aspects of health IT. Before joining HIMSS, Jeff was the team leader for corporate accounts at the Marwood Group, where he worked with nonprofit health systems, health IT vendors, professional societies, and trade associations, analyzing where they could most effectively influence legislative and regulatory processes and focus their advocacy efforts. So you can find the rest of his bio on our website at pcpcc.org. But I want to go ahead and hand it over to Jeff to go through his slide presentation today. So Jeff, take over.
All right. Great. Thank you so much, Caroline and Marcy and the entire PCPCC team for the opportunity to speak to you today. I really appreciate it, and hope to have a good dialogue via Q&A after my presentation. So as Caroline said, I'm going to talk about a couple different things today in terms of the agenda. I hope most folks know that the Meaningful Use Stage 3 Notice of Proposed Rulemaking was released last Friday. I'm going to run through some of the key points from there as we still digest exactly what's in the new requirements. And I want to talk a little more about interoperability initiatives and where things are happening right now in terms of what's happening with the Office of National Coordinator. There's some things happening on Capitol Hill related to interoperability as part of the larger sustainable growth rate physician payment fix. And then I want to talk about health IT and kind of value-based care and some of the initiatives that HIMSS has going on. One in particular is our value suite, which I think personally is pretty neat and pretty helpful to the community as we talk about how to derive value and discuss value in terms of health IT and just healthcare delivery in general. So just to give you a little background on HIMSS, so we are a cause-based global enterprise. We focus on health IT, thought leadership. We produce education events, market research, and so on. Our real focus is on health IT enabling healthcare transformation. So that's really kind of our guiding mantra, so to speak, in terms of what we what we really try to push for. We were founded in 1961. We actually have about 57,000 individual members, of which about 2/3 of those are healthcare provider, governmental, or non-profit organization folks. We also have 640 corporations and 400 nonprofit partners that are members of HIMSS. And we actually have our annual conference coming up in Chicago just in about 2.5 weeks for those that may be interested in attending. There's more information on our website. So in terms of the Stage 3 NPRM, as I said, it was released on the 20th of March, so just last Friday. This is the third stage of meaningful use, and what CMS emphasized in this new NPRM was that they expect Stage 3 to be the final stage of meaningful use, which is welcome news to some folks, and so I think it's important to just clarify what CMS. There's actually 2 rules that are released with meaningful use. There's the rule from the Centers for Medicare and Medicaid Services that includes a lot of the policy requirements around meeting the meaningful use criteria, and then there's the standards and certification side of things that comes from the Office of the National Coordinator. So both rules were released, and I'll talk about both of them in kind of a different context. So what was in the CMS rule was, again, an emphasis on the fact that Stage 3 is going to be the final stage of meaningful use. There's going to be certain parts of Stage 1 and Stage 2 that are incorporated into this stage. And what another change that CMS proposed in this rule was the fact that all providers are going to be reporting on the Stage 3 level by 2018, regardless of where they are in the meaningful use program. Some folks joined this program in 2012 and have been progressing through Stage 1 and Stage 2. Meeting all the requirements. Other folks are just beginning to join the program. Some of the latecomers that are probably not going to receive any incentives for meeting the meaningful use requirements, but may avoid some of the payment investments down the road that would come for not meeting the meaningful use requirements. But folks are going to be expected to meet the Stage 3 requirements by 2018. And there's also the option that they included in this rule about 2017 being an optional year. So if there are some folks who maybe started the program back in 2011, 2012 timeframe and wanted to try to begin on the Stage 3 requirements in 2017 on a trial basis, there is that option. And one other change too, meaningful use had requirements around eligible professionals, which are physicians and so on. They would report on the calendar year for meaningful use previous stages. Hospitals were on the fiscal year since they're paid on the federal fiscal year. So what has happened in the consolidation is that everybody's going to report on the calendar year. So hospitals will change from federal fiscal year beginning October 1 and just start on January 1st for the regular calendar year. I think it's important that the real signal that providers and health IT stakeholders in general got from this rule is about, I think, can really be summarized in alignment and flexibility. And you'll see in a couple of the things that I'm going to talk about how CMS is trying to be more flexible in terms of the requirements of the program and how they're trying to align the program with other programs that they have going on. So here is just a little chart that shows where folks have been in the program and where they will be. I just put it up here to kind of illustrate what we're talking about from 2017 going forward, for those folks, again, who are ready to join the program. But for 2018, under the proposed rule, the requirement would be to start on Stage 3. And I should say, too, that the rule does discuss how down the road there could be some tweaks to Stage 3, some of the requirements and so on, but they don't anticipate another wholesale change, a Stage 4 or something along those lines. So, in a couple of years, I think that there could be some changes to Stage 3, some tweaks around the edges, but the idea would be that Stage 3 would be the final rule of the meaningful use program. So in terms of clinical quality measurement, when we talk about alignment, this is really the key part of the alignment piece of things. So, what CMS is going to do is trying to align the EHR incentive program with some of the CMS quality reporting programs, such as the Physician Quality Reporting System and the Hospital Inpatient Quality Reporting System. So those three programs will have reporting requirements that are aligned. So providers that are going to be reporting for the IQR or the PQRS will also at the same time report their measures for the EHR incentive program. I think that's a step in the right direction given the burden of some of the reporting requirements and so on. So not having to report the information twice is something that should help to ease the burden for providers, and something that providers have been asking for. So, and what CMS is also going to do is encourage providers to submit their CQM data through electronic means in 2017, and then try to require all electronic submission when it's feasible, starting in 2018. And there are some caveats, some specifics in the rule that they talk about. And again, the idea is that everyone is going to start on this calendar year reporting basis, payment basis, and so on, beginning in 2017. And then make it fortified in 2018 for sure. So, when we talk about the objectives, folks have had questions about the burden and the objectives of the measures so far. What they've tried to do is streamline things again in terms of adding some flexibility to the program, and they've really identified 8 of these program goals of objectives, and they're on the screen right now in terms of what's included in the proposed rule. So you can see that they have things about protecting patient health information and electronic prescribing and health information exchange, coordination of care through patient engagement. These are the real pillars of the Meaningful Use program, and what they've tried to do is consolidate them down to 8 objectives. I would say that when you dig a little bit deeper into the rule, underneath each of these objectives, there are several measures that providers are going to have to abide by. So when they talk about only having 8 objectives as part of the Meaningful Use program going forward in 2017 for that optional year, and 2018 permanently, there is a little bit of it's a bit of a misnomer, I will say, because there are objectives, several objectives under each of these that folks have to meet. So depending on if you're a physician private practice or a hospital receiving incentives, or you could have 15 to 20 measures that you have to meet, have to report on to be meaningful use compliant. So that's something that we have to take a deeper look at as we move forward to ensure that providers are going to be reporting on things that really matter in terms of transforming healthcare. So I will say too that in the ONC side of things, in the ONC rule, there is a lot of talk about enabling interoperability, and I'll talk about the interoperability roadmap in a few moments. But I just wanted to point out some of the things here related to interoperability. And what ONC again controls is the standards certification side of things. So that's really where their levers are. So they talk about interoperability and improving interoperability by adopting new and updated vocabulary and content standards for structured recording and exchange of health information, using a common clinical data set that's composed of data primarily expressed using adopted standards, and then testing and identified content exchange standard, this CCDA standards, the Consolidated Clinical Document Architecture Standard. So there's also talk in the ONC rule about facilitating the accessibility and exchange of electronic health information by enhanced data portability. This is the whole API application program interface capability that there's great detail on in the proposed rule. And then again, the idea about updated vocabulary and content standards. So I think it's also important to mention one thing that isn't in the rule is this idea of an announcement that happened from CMS actually at the beginning of February, where CMS was talking about the meaningful use rules in 2015. And what they actually said in a blog posting by Patrick Conway, who holds several different, is an associate administrator at CMS, what they actually talked about at this blog posting was that there was going to be some changes made to the Meaningful Use program in 2015. Providers have been clamoring for changes to the program to reduce the reporting period for 2015 down from a full year to 90 days. And what CMS indicated in again, the intent to publish a regulation related to shortening the reporting period in 2015 to 90 days. So that was one thing that I think that they need a separate regulatory vehicle to do that, since Stage 3 is really focused on 2017 and in 2018 and beyond, to actually make it germane to the rulemaking process. They need to have a separate rule for that. But I think they sent a very strong signal to the market, to the community, that that's what they were going to do, was shorten the reporting period for 2015. Now we're just waiting for the specifics around that to happen. So there was nothing included in this rule. I will say that this new rule related to the 2015 reporting period has been sent to the Office of Management and Budget at the White House for review. So it's definitely in process right now, being evaluated and so on. So moving on, I just wanted to talk again about what's happening with the interoperability roadmap at the Office of National Coordinator. We, on the end of January, we got the interoperability roadmap, which was a draft version, open for public comment. Comments are actually due next Friday, April 3rd. HIMSS is busily working on finalizing our comments. But there's also a standards advisory document that was sent out that relates to kind of the best practice standards that are out there that providers are using to be interoperable with their other folks in their community, in their region, and so on. So that's a whole separate document. That's a separate comment period. Those comments are due at the beginning of May, and we're also working on comments there. So I'm happy to talk a little bit more about that. But I'm going to really focus on the interoperability roadmap from here on out, and just talk a little bit about what's in there, what the vision is from the Office of the National Coordinator, and where some of the changes that we would like to see in the roadmap. So what ONC takes a significant amount of time talking about is about how health IT is an important contributor to improving health outcomes, improving quality, lowering healthcare costs, and health IT is there to really facilitate the secure, efficient, and effective sharing of health information when and where it is needed. So another thing that they also talk about is about how healthcare is, and I'm sure most of you are really on the front lines of this. Healthcare is really going beyond institutional care delivery and healthcare providers to a broad view of a patient-centered health. And care is being given more in the community and home-based services. It's where it's less costly and more convenient for individuals and caregivers. And then the whole idea about determinants of health and how they're social and they're influenced by so many actions that take place out of a traditional care delivery system. So all those things need to be incorporated when we're talking about interoperability. So those are some of the considerations that they discussed in the roadmap document. So one thing that the interoperability is really leading to, and what ONC would like to see, is interoperability contributing to support a learning healthcare system. The learning healthcare system identified by the Institute of Medicine, several years ago. Most of you have probably seen this graphic here about information moving from setting to setting of care, from provider to provider. There has to be a high degree of interoperability. All these systems have to interoperate if we're going to get to a learning healthcare system, and then how this all contributes to sharing information for research purposes and for community population health and so on is also a very important part of this. The real vision that they laid out in the roadmap is really in 3 different stages. From 2015 to 2017, the idea is what ONC would like to see is a nationwide ability to send, receive, find, and use a common clinical data set. For 2018 to 2020, the idea is to expand interoperability data, users, sophistication, and scale. And then from 2021 to 2024, 10 years out, what we're talking about is a broad-scale learning healthcare system, achieving that broad-scale learning healthcare system. And underlying these three kind of 6 3, 6, and 10-year time frame is really these 5 building blocks. And in terms of the building blocks, there's core technical standards and functions. Those are the standards that actually underlie the entire technical side of things for interoperability. Then there's the idea about certification and ensuring that folks that are purchasing EHR systems, purchasing other health IT, that they know what they're buying. There's some sort of assurance that it's happening, that they will be able to adopt and optimize some sort of interoperable system. So certification is a big piece of that. And then, of course, one of the most important pieces of these building blocks is the privacy and security protections, making sure that health information, when it's being transferred and when it's being interoperable, there's some privacy and security protections on that. And the idea about a supportive business, clinical, cultural, and regulatory environment. The idea of this is not just a federal initiative. This has to be something that comes from help from the private sector, help from the patient and person-centered care community. There has to be a change in regulatory side of things, but there also has to be contributions from other players, state-based interoperability initiatives, and so on. And then underlying all of this is really the governance rules. What kind of entity is going to oversee this entire enterprise? How that all is going to function is something that needs to be worked out in the roadmap document. So just to run through some of the principles that are in the roadmap, I think that we've really touched on a lot of these points already, but building upon existing health IT infrastructure. We don't need to recreate the wheel here to make interoperability work. We have a solid infrastructure. We need to try to capitalize on that. Empowering individuals. I think one thing that HIMSS is going to emphasize in our comment letter is the fact that we want patients to be the drivers of their own care, and we also want patients to be activated so they can demand that their providers be interoperable, that they're attending physician practice or getting care from a hospital that is interoperable. Obviously that's a key part when we talk about the supportive environment. I think that's a key part that we need to talk about. But the idea about one size does not fit all. Interoperability is going to mean different things to different folks. So making sure that we are using all the means necessary to make an interoperable environment progress and so on. So again, one thing that they really did emphasize is this by the end of 2017, having a majority of individuals and providers across the care continuum, not just in the providers that are covered by the EHR incentive program, but across the care continuum, have the ability to send, receive, find, and use a common set of electronic clinical information. So that's a kind of a key tenet of the interoperability roadmap, and something that I think some folks have been questioning related to whether that's possible to get to that point. So in terms of this target, there's also the idea about using community-based services and social services and public health and the research community, making sure that they are included in this idea. Again, to get back to the idea about a learning healthcare system, we need this support of the public health and the research community, and making sure that there's some tie-in between this health information and some of the social services to again ensure that we're caring for the whole patient and also I should emphasize too, caring for the right patient and including some sort of patient matching infrastructure has to be part of this entire idea, because that's one of the real issues that when we talk about interoperability that we need to really emphasize. The in terms of standardized data elements, there is demographics, and all those things are going to enable better patient matching and linking of electronic health information. So the 4 critical near-term actions, I think we've already kind of discussed these. These basically come from the building blocks, so I will just stop there. But again, privacy and security underlying everything that we do here to ensure that we have a system that folks can trust, that providers can trust, that we're in an environment where sharing information is something that can be as safe as possible for all participants in the system. So, as I said, there were some interoperability provisions in the SDR legislation. So we have a couple of moving pieces here that I think it's important to emphasize. We have obviously there's some interoperability pieces in the ONC rule as part of Meaningful Use Stage 3 that I discussed. There's also this public comment period that's happening right now and ending very soon on the interoperability roadmap. But then also, this new wrench in the entire plan is the idea about Congress weighing in and with the SGR provision. So there, I know that you all have been briefed on what's happening with the SGR. So I'll just say that there's a couple of things here. That one of the provisions in the SGR physician payment fix is the idea that EHRs be interoperable by 2018, and also a provision in there about prohibiting providers from deliberately blocking information sharing with other EHR vendor products. So that's something that the legislation as it currently stands, and I know it's being debated in the House and shortly go to the Senate. But the idea of getting a GAO report about that, and so that's something that's in process. But the idea again, I think that in general the SGR fits into what's kind of already happening at ONC and at the Centers for Medicare and Medicaid Services in terms of bringing the reporting programs together. That's something obviously that was in the Stage 3 rule, and this idea about being interoperable by 2018 is is something that's in the Stage 3 rule as well. And how this all works together, I think remains to be seen. So it's something we'll obviously be keeping a close watch on. So I just want to talk a little bit about health IT value and so on. Where we're at HIMSS is really focused on the announcement by CMS recently related to the framework that they established for the different thresholds that they expect to meet over the next several years. They establish different categories. They have Category 1 about fee-for-service that has no link to payment or quality. There's Category 2, which is fee-for-service that has a link to payment to quality. Category 3 is this alternative payment models that are built on this fee-for-service architecture, and then Category 4 is population-based payment. So I think most of you have probably seen this graphic that came out, again, announcement from CMS and also from HHS Secretary Burwell, the idea about moving, 2016 having these certain thresholds for the alternative payment models and population-based payments, moving those in 2016 from 30% of all Medicare payments to 50% by 2018. And then the larger light blue circle there is again categories 2 to 4 that has some fee-for-service linked payments, fee-for-service quality linked payments, I should say, growing from 85% to 90% of all Medicare payments. So this is a goal. I think it's something that CMS is going to provide a lot more specifics on in very shortly in some of their annual payment updates, the physician fee schedule, the IPPS rule. Will include more information in there about how they expect to reach these goals. So what HIMSS has been really focused on is establishing our health IT value suite. So again, for us, it all comes back to value in terms of demonstrating value, what folks are getting in terms of the investment that they're making in health IT, the investment that they're making in improved care delivery, in participating in some of these alternative payment models, accountable care organizations, or patient-centered medical homes, and so on. So, but this idea about a value suite is something that we classified based on our 5 steps model, and that classifies health IT value in terms of 5 areas. The first is satisfaction. Then it's about treatment and clinical area. And then there's electronic data information side of things, prevention and patient education, and then savings. So what we've done is take that framework, the STEPS framework, and put together a value suite. It's something that lives on our website. We collect demonstrations of value from across the healthcare community. There's about 1,000 organizations that have contributed to this thus far. There are about over 10,000 examples of specific value that have been identified and kind of categorized on our website. So there's 80 specific types of value, and we can drill. I'll show you how we drill down into a little bit in a few moments. But 80 specific types of value, lessons learned, and so on. So the idea is when there is some sort of demonstration of value in the community, those folks can contribute that information. And if you all have information that's not already on our website, I would encourage you to include it here, because I think it's a pretty neat model that we've set up. But again, these are the different categories in our STEPS model. Satisfaction focuses on the improved communications with patients. Treatment and clinical focuses on patient safety and reducing medical errors. And then electronic information data is about using evidence-based guidelines. And prevention and patient education focused on increasing immunizations and longitudinal patient analysis. And then the savings piece of things, increased volume, reduction in days and accounts receivable, and so on. So I didn't want to do a live demonstration of our model, but if you go to our website, I included the website in the previous slide. But drilling down from our five steps point model, you can see here what I pulled out was a treatment and clinical side of things that drills down into 3 different areas. And you can see from the treatment and clinical side of things down to quality of care, efficiencies, or safety. And then drilling down even further about reducing hospital-acquired infections or decreasing response time to patient requests and so on. So the one that I chose here was a reduction in readmissions. And then so we have 4 different instances of value being derived there. So these are not all peer-reviewed studies that are out there. Sometimes folks have something that they want to contribute that is not peer-reviewed yet. So we put it up. We put up this information there just so folks can get an idea. We try to get as many peer-reviewed studies as we can, but the idea is that more demonstrations of value and trying to connect the dots for folks about how maybe one provider has done it in the past, and how somebody can reach out to them, contact them to figure out if they're in similar circumstances and they want to get more information about that. So that's really it for me. I'm happy to I haven't been looking at the box over here, but if there are any questions, I'm happy to answer them.
Perfect, Jeff. Thank you so much for this presentation. I think it's not only very informative, but very timely, as you mentioned, with the meaningful use. Stage 3 proposal coming out now just last week, and we have the House passing a doc fix today, and hopefully we'll have some success tomorrow in the Senate side. And as you mentioned, there's a lot of things related to meaningful use and how payment structures might change around that once this all comes together. Before we get to the questions that are starting to roll in, and as Jeff mentioned, please continue to add your questions and or comments into the box, and I'll pose those to Jeff. But we've been talking about interoperability for a long time, and from the patients especially that we talk to, there's still a major frustration on that front. Why has it taken us as long as it has? And you've got your new roadmap out that talks about when we hope to see this interoperability really happening across healthcare providers and even into community-based providers. What have been some of the barriers and challenges? Why haven't we gotten further along this path than we are today?
So, I don't think that there is one magic bullet about solving interoperability, but I would say that there have been several efforts that have tried to entice providers and even health IT vendors to be more interoperable. I think what we are recommending in our comments on the on the roadmap are a couple things, and one of them is to establish a governance process that is holistic and coordinated among all the different entities. There have been several kind of federally supported, federally driven efforts over the past several years about trying to make our health system more interoperable and get folks to a certain level of interoperability. Those have worked, I think, in different parts. But what we see as a real important piece coming out of this out of the roadmap discussions and finalizing the roadmap is the idea of some sort of holistic solution, and that's going to involve obviously the federal side of things. But when I talked about the private sector being involved, having the vendor community, having the provider community be able to contribute, having the health information exchange organizations contribute to the entire solution, getting folks on board and bought into trying to be part of the solution and contribute to reaching the goal of an interoperable environment by 2017 or some point shortly thereafter. I think another piece of it is incentives and incentivizing providers to be part of this. And the roadmap does talk about how CMS has as part of all their alternative payment models and all the talk around relating about the push to more value-based care, about how they have the ability to use certain policy levers internally to incentivize folks to be more interoperable. And they, I think that the model that they've kind of been discussing is trying to incentivize folks and giving them the opportunity to be interoperable. And then if they aren't interoperable or don't get to a point where they can share information, there are payment adjustments that could be a possibility at the end. Or they also discuss in the roadmap the idea about being a Medicare provider or a Medicaid provider, having the conditions of participation to be one of those providers, say that you have to be able to share information with other providers in the community and so on. So I think that there are a lot of levers that can be pulled here, but looking at this holistically and making sure that it's coordinated. So again, we're kind of asking for this to happen in the private sector, to continue that, to make sure that folks have an opportunity to buy into the process, contribute to the process. ONC would set the rules of the road initially through the roadmap, through further guidance, and then kind of they would still be part of the process. CMS would still be part of the process, but it would be private sector led to make sure that, again, that everybody has the opportunity to buy in and contribute. So I think looking at it holistically in kind of a well-coordinated fashion is something that we think would help, would go a long way to not repeating the the challenges that we've had over the past several years.
Yeah, and I think a lot of the issues that play into what kind of information is shared and how it's shared, certainly a big part of it is the actual technology that's underlying it, but then there's other issues that come into play. We've gotten a couple questions that are specific to different elements of a patient's care, one around behavioral health, mental health, and then also to Medicaid programs, more specifically with the post-acute providers or the SNFs. Can you talk a little bit about some of the issues that you've seen playing out in both of those areas?
Yeah, and one thing I think I alluded to in the roadmap discussion was the fact that ONC talks about interoperability not just for the programs that come under, or the settings of care or providers that come under the EHR incentive program, either on the Medicare or Medicaid side. They want to involve, this has to be a community-wide effort. So the idea of behavioral health, other settings of care, being interoperable is something that an aspiration of where they would like to go. I think that the real focus of ONC, obviously, over the last several years has been on the EHR incentive program and the providers that are part of it. What they talked about, what they proposed in the roadmap was the idea of maybe having certification programs for IT beyond what's covered in the EHR incentive program. Again, so providers that maybe are a little hesitant to make an investment in health IT technology would be able to look to a certification program to figure out what they are buying, what meets requirements that ONC thinks those providers would need to be interoperable and to share information and treat their patients. So the idea of a certification program is something that that I think is has some legs in the discussion. So I would emphasize that point. In terms of states and Medicaid programs, the roadmap does talk about what's happening on the state side, and there are obviously some state laws that conflict with federal laws. So I think trying to harmonize all of those together is obviously a huge undertaking, but I think it's gotten the conversation reinvigorated by including that in the roadmap. So it's something that federal officials are looking at. I think they've been reaching out to some state officials, but making sure that there's some sort of harmonization between what's happening on the federal side in terms of interoperability, and that there are real the roadblocks or the challenges on the state side are minimized as much as possible.
Yeah, and this just made me think too. Another big topic that we talk about is on the patient side. All of this is really impacting and driving and influencing or trying to incentivize on the provider side. But on the patient side, I'm sure every day there's 100 new apps that come out and give patients the ability to track information about their own health, collect all kinds of information. Is there any conversation that's going on specifically about how that gets integrated into wider health information systems?
Yes, the so-called patient-generated health data is a part of our comment letter that we're, again, don't quote me on what's in the comment letter because it's still being finalized and has to be approved by our board and so on. But in our comment letter, we do talk about patient-generated health data, the importance of it, and trying to figure out a way to incorporate it into the electronic health record or some other health IT technology that doctors can use, that patients can use, in doing it in such a way that that really helps care delivery. And again, the idea about so many social determinants, so much health care, taking place outside of traditional settings of care. Making sure that there's a means to contribute to that, and making sure that information is interoperable. I think this goes beyond Fitbits or Apple Watches and collecting step counts and so on. But I think that does figure into the larger thing. And I think that I tried to get the point across that we would like to get to a point where, again, the patients are activated and understand what it means when their provider is interoperable and can share health information, and what it means when their provider is not up to that point. So patients being educated about that, and some sort of health literacy about that, so they can get to a point where they can ask their providers to be interoperable, or use providers who are at that higher interoperable state. So that patients figure, I think, very prominently into our comments. They figure very prominently into what ONC included in the roadmap. So I think they will be a contributing factor to this governance process going forward.
Fantastic. I've got a question here about the STEP site that you talked about. They want to know, is there a way that someone can identify any measures related to a specific disease or condition, like COPD?
They can drill down in terms of it does not get into that level of granularity, but they could, again, maybe the example that I used about readmissions, maybe that way they could get to a place where they could kind of look at readmissions or look at other, I think, one step higher kind of level of classification in terms of than a specific disease state. I think this is still a work in progress for us. I think that is that's something interesting. I don't know if we've gotten that question quite yet in terms of the development of this, but we've tried to classify things along our steps model and then drill down from there, but have not been able to drill down. And as we get more submissions and more information, we will be able to kind of drill down a little bit more to get to maybe to like readmissions and then to a specific disease state that may contribute to readmissions and so on.
Fantastic. So there's a few questions here about additional resources required for providers or health systems to enact some of this technology, or maybe the technology that they have in place is not going to serve them well in this new environment of interoperability. Are you anticipating beyond what you talked about in the various new payment models that are coming out that will incentivize the use of technologies and sharing of information? Are there other resources that you see coming down the pike that providers might be able to tap into? We've been talking a lot about this, all the changes that have to happen in a practice until you get to this point where you can start to really participate in some of these advanced payment models. Are there other resources that are at hand or that you see coming forward on that front?
Yeah, I think that, again, I don't think that there are dollars necessarily that are going to be available for incentivizing providers to become interoperable. I think that there will be, I think that eventually we'll probably get to the point where we can, to participate in Medicare or to participate in a particular program in Medicare, whether it's a new ACO model or something like that, there will have to be the demonstration of interoperability. And then, that participating in maybe in that type of model, that type of program, providers would be able to avail themselves of certain, certain incentives or greater dollars. But having some sort of across the board, payment system or incentivizing providers to do that, I don't think that that's probably in the cards. I think that there's still a lot of questions swirling around about the meaningful use program and how it hasn't been effective, and what has the government gotten for the $29 billion investment that they've made in gaining more widespread use of EHRs and other and health technology. So I think that there's probably going to be an emphasis on specific programs within CMS. It maybe get to the point again where the conditions of participation related to Medicare or Medicaid participation for providers require an interoperability function. But I do think that the idea of having some sort of payment adjustment structure, could be something that's discussed down the road if these efforts do not coalesce like folks on Capitol Hill, folks within the agencies, want to see them happen.
Well, since we're kind of talking about the payment incentive part of that and how you talked in your presentation about this new, as we heard yesterday, these audacious goals that CMS has put out there on getting healthcare providers more engaged and participating in alternative payment systems. So we've got everything on the technology side has been, for the most part, pretty aligned around a fee-for-service environment. So the technology really helps enable healthcare providers do their documentation and their billing all together in a way that maximizes their ability and make it more efficient for them to bill for the services they're providing. Now as we move into an environment where we're trying to get practices to think about these population-based payment models, how do you envision, or have the conversations that you've been a part of been moving to help enable technology in that way, where the documentation might look a little bit differently and there might not be the need for the billing part of the technology in the way that it's happened in the past?
Yeah, I think that what I talked about related to stage 3 of meaningful use and a common clinical data set, I think that that is something that is a big part of that conversation. Having certain elements of a record that are common across platform, common across vendor or provider, so that there are certain pieces of information that are formatted in the same way, that have standards around that folks can can help by abiding by those standards to make sure that they can be interoperable and so on. I think that's probably a real key part of this entire discussion.
Yeah, I think we're going to see
that's a good
lot
question.
of
I think oh, I'm sorry. I was just going to say I think that's a very good question, and I think that it's something that is going to be evolving over the next several years as we get more interoperable and move more towards that division that ONC has established.
Perfect. Yeah, lots of conversations still to be had on that front for sure, and we're just starting down that path, but exciting times on that front for sure. So I think you've already answered this question, maybe not directly, but in talking in your points about having the private marketplace kind of drive some of these changes and kind of leading the horse to water. There's a question around, has the federal government abandoned the idea of having a national EHR that's free to all?
I think that there are some free free products out there. I think that the model that we're kind of working under at this time is not so federally driven in terms of that particular aspiration. I wouldn't say that it's I think what the federal government is trying to do is set standards and certify products, and I think that they are going to focus on trying to expand that beyond the traditional meaningful use providers that currently stand for the program, and try to branch out to other providers. And I think the idea is market-based in that once the standards are set and folks can buy into those standards, having the private sector create products around that that work on those standards and so on, and then using those products to to get folks into more integrated into the health IT world.
Fantastic. So is there a place on the HIMSS website where people can go and get some examples of some communities or maybe some health systems that have really gone ahead of the game and are really innovative in this area, have demonstrated some great examples of how interoperability can work? Are there some examples that already are coming to the forefront that you're highlighting or
yeah,
I
would say too that I would encourage people to go to the Value Suite website. Again, it's populated with about 10,000 different examples of value, but we also have another program called our Davies Award programs, which is really for the real high achievers in terms of using health IT to improve healthcare transformation. There's again, it's the Davies Award program, and I can send more information over about that. And then also we have, through our HIMSS Analytics branch of HIMSS North America, there is a an MRAM model, which is an adoption model related to EMRs that kind of shows folks that have achieved stage 6 or stage 7 of our MRAM model. And again, this should not be confused with the stages of the Meaningful Use Program, but stage 6 and stage 7 achievers of our MRAM model are folks who are already really functioning at a stage 3 of meaningful use level, basically, and maybe even beyond what the requirements of stage 3 are. So that may be a good place to start in terms of folks who have achieved those levels. And it's a part of being interoperable and having strong patient engagement programs. There's a lot of different factors that go into reaching those goals in terms of stage 6 or stage 7 of our MRAM model.
Fantastic. And as you mentioned, you've got your big conference coming up in Chicago, and I think a lot of people on the line today and their colleagues will be in attendance and have an opportunity to talk directly with a lot of these companies who are developing this technology and really trying to be on the front edge of a lot of this work. And I think they'll have a great opportunity there to talk directly with them and get more information on your website as well.
Yep. No. Yeah. It's going to be. We're expecting close to 40,000 people in Chicago for our conference, so it should be. It's going to be a great show, and there's going to be a lot of talk about all these policy issues.
Absolutely. Well, we've got a few other questions that are wanting to kind of have us do a deeper dive on the SGR repeal that we don't have time for today, but certainly stay tuned. Continue to watch our communications and check in with us on our website at PCPCC.org. We're closely following all of this activity and tracking it and are cautiously optimistic based on what happened today. So if you want additional information about that, you can link on our website. We've got some letters that sent up to the Hill that call for some of this this advanced payment model, and certainly excited about the direction it's headed, and especially excited that they're recognizing the care that happens in a patient-centered medical home, and as we look towards advanced primary care models, really do require more resources, certainly as it pertains to expanding the care team, more engagement with patients, and obviously, as we're talking about here today, so much of the technology is going to be critical to all of this measurement and reporting and metrics as we start to align that payment more with value and not just with volume. So thanks again, Jeff, so much for your presentation today. I know we have several other questions coming in. We'll send those on to Jeff, and if he's able to get some more detailed answers for you, especially for those that we didn't get to today. We will have a copy of this website, of this presentation up on our website within 24 hours, and if you need a copy of the slides, you'll be able to access them there as well. So thanks again, and we look forward to talking to you all next month.
Thank you.
Bye-bye.